Awesome. Welcome to Planetary Health First, Mars Next. My name is Michael Mann. I'll be hosting, moderating today. We have some amazing guests today talking about some important things, really the challenges right now, navigating headwinds, AI risk, and regulatory crosswinds, and the healthcare payer strategy. And Tom, as you're on my right, would you first quickly introduce yourself? Great to have you here.
Yeah, absolutely. Thanks for having me. Excited to be here. My name is Tom Schenk. I'm the Vice President of Payer Strategy and Success for Vertex Health. We're the nation's and the world's largest risk adjustment and quality improvement coding and abstraction entity. And we specialize in retrieval operations, supporting both financial success as well as quality and clinical success in support of health plans and providers nationally. Quick background on me is going into my 15th year supporting health plans on the vendor side. I've worked with about 3/4 of the current payers on the market today. Been through a lot of challenges. I've had a lot of really interesting roles, a lot of challenging roles, a lot of exciting ones. A lot of it has been in the medical record retrieval and review space. I did spend a number of years consulting for health plans to strategically help them assess and align internal priorities, external partnerships, and just drive towards success and risk and quality. And then around the COVID timeframe, I jumped into the clinical side of the house and was helping with cardiometabolic health, especially as COVID really started to rear up, providing virtual clinical management solutions, and then took an exciting role on the care navigation side as well. So as far as working with payers, almost most of the departments that engage with payers or have anything to do with financial success, it's been an exciting ride over the last 15 years, helping them navigate through.
Excellent. Rahan.
Yeah, great to be here. Raihan Faruqi. I'm an internal medicine physician by training. I've spent the last decade as a early stage health tech startup operator at pre-seed to Series A companies. Also serve as an advisor and consultant at Connectify Health, my boutique consulting firm, where I help startups get to market faster. Kind of my focus lies in building the clinical and financial ROI story at early stage startup, and have had a host of roles in go-to-market strategy, business development, payer provider partnerships, clinical product strategy, and clinical validation at B2B AI SaaS startups and kind of B2B2C tech-enabled services companies going into payers and employers. A lot of my background lies in AI and ML-powered clinical workflow tooling, generative AI and LLM use cases, and especially now the use of agentic AI co-pilots and scribes all throughout the tech stack.
Awesome to have you here. Vandana.
Hey, thanks for inviting me, Michael, to participate. My name is Vandana Barani. I'm the managing partner of 8B Advisors. We're a boutique consulting firm supporting payers, providers, and technology companies in achieving their quality, risk adjustment, operational, and interoperability goals. My area of focus has really been in terms of anchoring in quality and really being able to layer on top of quality fundamentals for a health plan or within the ecosystem, layering in risk adjustment, operations, whether clinical or just process improvement, and interoperability with a heavy focus on how do we find a way to simplify the healthcare that we currently operate within and do better for the beneficiaries or patients that we're serving.
Well, this is great. I'm so glad you're here. This is an awesome Friday to be going through this. There are some severe tailwinds and headwinds in the payer space. Who would like to start on that?
Yeah, happy to start. We are certainly seeing digital transformation and automation opportunities. We have AI-driven tools in prior auth, claims automation, virtual care triage, navigation, and the promise is really to decrease administrative costs and improve member experience. I think when health plans are looking at their bottom line, they're looking at COGS and labor cost, specifically AI, but also agents now have real potential to automate and then really kind of drive down some of that labor cost.
Yeah, I think that's a really that's a great starting point, Rayhan. I would agree that there's a lot of opportunity from a payer perspective to find ways to streamline and create efficiencies through AI and additional technologies. I would say from a headwind perspective, the focus on AI has really kind of come up quickly everywhere you go, everyone you talk to, especially from a technology point of view. It is incorporating AI into their conversations. I think as a former payer um, executive, one of the concerns that I have is kind of the unknown space as we implement some of these technologies and what that's really going to mean within systems that are antiquated, within data systems that cannot manage the provenance of data as it is ingested across different tools or solutions.
I'm seeing, firsthand experience. I mean, AI has been around forever, right? Coming back to early days of before everyone was even on EHR. Like, can your AI handle actual handwritten notes from physicians, and the challenges of, actually reducing, your spend and increasing, overall success in the, quality and risk adjustment use cases. But I'm just shocked. I've been doing a huge deep dive into clinical documentation integrity recently, and I had no idea of the volume of regulations that are trailing behind a lot of this evolving technology. And AI, they're hearing constantly that every 4 to 6 months is doubling in its power and its capabilities. And there's always the concern of how do we continue to leverage this without harming patients, without having a lot of those adverse impacts and effects. So I'm just excited to see this evolve, and hopefully evolve the right way. Like, there's a lot of focus, and there was a large bill that passed last year that modified the ACA around the non-discriminatory use of AI, and the actual components of it I just found really shocking and alarming, that unintentionally a lot of what sits behind on that AI and what it was trained on and what it's built off of and what it's pulling from to provide responses was having a very discriminatory effect on a lot of different types of communities and individuals across the country. I mean, now what we're finding is that the regulations, after discovering all of this, is that they're forced to enact policies, procedures, enact safeguards, and also requirements around training for anyone that has anything to do with the AI or the use of it. And no longer can health plans or providers just lean on the assumption and expectation that the vendor is doing what's best for their organization or their insured population or their the practice in which they're providing care to those members, because where it's pretty prevalent that there's a lot of errors that have been made, and it's especially in the actual delivery of care around the recommendations around the clinical care. And I know, Dr. Rayhan, you've got a lot of experience in seeing a lot of that kind of take place. But the biases that are in some of these algorithms that are being leveraged, there's 280 total bills that I just discovered at the state level where they're actually all on the House floor. I think 35 have already been passed in the last 5 to 6 months. And so you're seeing this evolution of AI. You're seeing the regulations try to keep pace to protect patients and individuals. It's just it's a wild space. I think we're in the middle of a dot-com bubble, and a lot of folks really haven't realized it yet. But it's definitely an exciting time.
You said something really interesting about payers and providers not just assuming that their vendors now are doing the right thing. I don't think that, I would hope that no one was really assuming that previously. I think it's even more critical now to truly understand what your problem is that you're trying to solve, because as you are talking to different partners or vendors in the space, there's a lot of solutions. And what I've seen is that most people don't know what problem they're trying to solve. And when you start to introduce AI or, a variety of these different tools, you can go down the wrong path pretty quickly. And so hence the need for a significant amount of regulation that includes train your users. I mean, what a random thought.
It's been interesting to see. I went to my very first ever payment integrity and fraud, waste, and abuse conference. 15 years in this space, and kind of seeing the silos within a health plan of completely different departments, different focus points, but they're all trying to tackle the same exact challenges. And I was privileged enough to listen to the HCSE team talk at length about their approach to assessing AI. And you'll have individual siloed, teams, call it risk adjustment, call it payment integrity. AI is popping up all over the place. And what they were finding is a lot of vendors were showing a fairly shiny solution, and then there wasn't as much due diligence on the overall impact, the security, a lot of components around leveraging it. And to your point, like, what problem are you really trying to solve? And so HCSE took it as a use case approach. So every single use case that comes through, and they're looking at, potentially acquiring or building an AI internally, there was an entire AI task force that was assigned to review it. I just found that as an interesting approach. I think a lot of health plans and providers across the country could leverage to try to mitigate some of that risk, because it's just the ability for a solution to come in and to not actually solve your problem, and then all the risks that are associated with it. I just found really interesting.
Yeah, would love to. So sorry, go ahead.
Go ahead, man. Go ahead.
Yeah, would love to jump on that. This idea of AI governance and the opportunity for health plans to establish frameworks. I do see that as a tailwind and an opportunity, really building cross-functional AI governance boards. Plans definitely have the opportunity and really the urgency to establish committees, which includes legal, clinical, actuarial, and compliance leaders to oversee AI vendor use and deployment. And I think health plans can take a page from what's happening in the provider space with hospitals and providers that are doing the same thing. A lot of my colleagues are chief medical information officers. They have backgrounds in clinical informatics. And at various hospitals, you're also now seeing the kind of construction and formulation of these AI governance boards, because the practice of safe and responsible AI definitely is a shared enterprise. I think the second thing is really establishing vendor procurement standards, requiring all AI vendors to provide documentation on training data, bias testing, and especially post-deployment monitoring plans. As we think about kind of the core, problems that AI poses, it's very important to understand, how do we explain what bias in training data is? How do we explain efficacy and safety and privacy and liability? So there's a really big impetus now to be able to establish these frameworks, and it's very exciting to see conferences and boards popping up left and right. I think another area to really think through is that, again, we're in this evolving space because the large language models are shifting rapidly, especially the public ones. So this idea of governance is not a one-time check, right? We kind of need this real world monitoring, because the large language models are evolving. They're getting better. They're including chain of reasoning and explainability, which is really important. But then how do we translate that into the various use cases for plans and providers? What does that mean for ambient documentation? What does that mean for a claims denial? What does that mean for clinical documentation integrity? I think it's very important to be able to build it in that transparency.
What are some of the major pitfalls, or the pitfalls that you've seen, kind of maybe mistakes that providers or plans have made in standing up their governance programs? I think that's a really important activity for anyone that is entering into or currently starting to implement AI tools and technologies. And I perceive that many of them haven't really thought through some of that governance framework.
Yeah, I think there's several. I think the first is we have a lack of qualified talent. And I think that's the elephant in the room. We're seeing AI experts pop up all over the place. First of all, we haven't had this for a very long time. So it's not like we're magically going to have hundreds to thousands of AI governance experts exist. We actually need to train a workforce to do this. Now, there are folks who certainly have a background in machine learning and vendor procurement, like the various areas that we need, but we need to upskill. We need to upskill, we need to train, we need to kind of be able to deploy folks who have some experience, which means that, we need, courses, certificates, so on and so forth. So I see that infrastructure being built right now. I think we have to be very kind of transparent with the problem at hand, rapidly shifting field, not enough best practices, folks are not properly trained and qualified. So I think being very forthcoming and self-aware of the problem at hand, but then providing a training infrastructure to get folks up to speed as quickly as possible. I can give you one example of in the clinical space. I've been working in AI for the last 7, 8 years, but I am no expert by any stretch. But I get pinged by docs all the time who are in practices or even at hospitals. Like, how do I learn? I put together this guide, this healthcare AI resource guide, which listed courses to take, conferences to attend, Substack newsletters to read, KOLs and health system leaders to follow. And even having access to resources like that, like democratizing information, is super, super critical. There are several healthcare AI coalitions that have put out really fantastic frameworks, like the Coalition for Health AI, or CHAI, NIST, which is a government entity based in the Commerce Department, Valid AI out of Stanford, Health AI Partnership out of Duke. So these are coalitions that are now putting out frameworks, putting out standards. And some of the health plans and some big tech companies and other stakeholders are part of these coalitions. But I do see, I think, health plans as a vertical actually saying like, hey, look, no one's really speaking for us. We actually need to kind of band together and put out our own frameworks and standards. And I believe that will happen.
Mm. And I'd be interested in understanding, just kind of some of the events of the last year or two. There's definitely been a lot more non-industry focus on AI in healthcare. Have you seen, how are you seeing providers or health plans respond to that? And what are some of the opportunities that we yet have to appropriately address some of the concerns that are being?
Yeah, I think that's a great question. I mean, we have to really understand that, again, the consumer large language models that exist are very wide. If you've used ChatGPT or Claude or Grok or any of the available LLMs, those are not trained on very specific healthcare data. They're very widely general. They're like kind of trained on very general data. I think what that means for providers or for health plan execs or admins is understanding is, like, what is the source of truth, right? Because clearly this LLM is not the source of truth. But the source of truth is what we as an organization have built over time. So an area that I'm seeing a lot of growth in is what's called RAG, right? Which is retrieval augmented generation, which means, hey, we have our own source of truth, which is our database, our PDFs, our documents. We now want to be able to kind of connect those LLMs to our source of truth, right? A lot of AI agents are now actually kind of using this infrastructure that I'm describing, kind of connecting this generalized, database to now a more specific ground source truth that the corporate organization has, and now being able to put it on an output that gets filtered by the org, if that makes sense. I think that's the first thing to understand, is that we have ground source truth, right? Not ChatGPT or Grok or Gemini, but how can we, leveraging those platforms, kind of filter and add our ground source of truth to give an output that's helpful for our staff, that's helpful for our patients. When you think about, patient education or document summarization or so on and so forth.
Yeah,
I love that. I think there's so much that is probably not even realized, especially in the plan space. And I would say not necessarily some of the nationals, sorry to interrupt you, Tom, not the nationals, but where I worry is the the level below the nationals, right? That are kind of venturing into some of these into this space, but yet don't have the resources, obviously some of the talent pool or access to the talent, don't know of all of the resources that you just in like 10 seconds or less were able to tick off, which I think is amazing. And so there's so much yet for people to unearth and to really be able to have access to. So appreciate it. I think, Michael, some of those resources might be helpful to have links to, as we complete the webinar.
Yeah, I think you're spot on with the resources. And Farhan, I just had a conversation with a founder's AI company, and they're doing exactly what you're saying. And, as their competitive advantage, they're building out their own data set specifically. And I'm sure they're doing exactly, then going back and whatever those other models are they're using, whether it be, I don't know, but it seems like that is an opportunity for organizations to really get their data at the source, kind of those models. So, good point. We definitely want some resources here. So from this afterwards, we will have some resources that are appropriate. And so look forward to getting that out there as well.
I think, Farhan, it was a great question you had around how can a health plan, and Dr. Aaron, to your comment as well, with the lack of talent that's just common everywhere. What can a health plan or provider group do, and where do you start? I guess that's the real challenge, is where do we start? And I think, as painful as a lot of them it can be working through the regulatory process, but of the 250 bills that are currently pended nationally at the state level, even just taking a look at the proposed legislation, if you just type in your state or the states that you cover and look up AI-related bills impacting healthcare, you're going to find a ton. I know New York has passed one recently, Mississippi, Kentucky. I believe there's one in Utah. Maryland has just passed one. And what they're attempting to do, first and foremost, is structuring what is unlawful and what is lawful use of AI directly related and pertaining to healthcare. And so what they're doing is they're building a framework in which a set of requirements that organizations have to follow pertaining to the transparency and disclosure. So if you're leveraging AI in healthcare, these bills are mandating that you have to tell your provider, and the member has to be notified that you're using AI, and how you go about doing that as well. I think the oversight and required reporting on you testing that AI and its use and its impact. And then, the task force obviously was a key point that we already hit on, but when it comes to the lawful and unlawful component, I mean, the ramifications are massive. And so I think from a starting point, just look at what your state has proposed. And a lot of them may not even make it to the House floor. I know that the ACA bill that passed in July of last year, it was almost copy and pasted over for Medicare Advantage. It was this close to being passed, that had a massive framework around AI. I know a lot of it came about with bipartisan support around some of the prior auth discussions and debates that have taken place. But the bill was far overreaching above and beyond just specific the prior auth use cases. And so I think it's important for you to just look at those proposed bills and build a framework internally. And then it's a good spot to start.
Yeah, I think, Tom, your overview of the proposed AI healthcare legislation is really opportune. I think it's certainly accurate that on the state level and even the federal level, right, there are several committees that are looking at AI broadly, but there are certainly healthcare specific bills. And I think it's interesting because like these policy recommendations are coming, at a time when there's like very significant headwinds, both on the regulatory front and just on the commercial front. I mean, when we think about the state of play of health plans right now, there's a lot of vulnerability, right? We have rising medical loss ratios, especially in Medicare Advantage. For example, high cost of drugs, chemotherapy. We have this nagging post-pandemic catch-up care where folks, again, post-pandemic have come back to the hospital for procedures and for visits, and that's increased inpatient utilization. And we saw, many of the large nationals, especially in their kind of reports, struggle, especially the chronic care needs of aging populations only goes up. Star ratings and audits, right? Really kind of thinking through the fundamental, I think, issue with stars. And I'd be curious, both of your kind of inputs on, does the stars program, serve its intended purpose? It seems to be like increasingly disconnected from clinical outcomes. We see a lot of plans are kind of gaming stars metrics, right? Medication adherence, HEDIS gap closure doesn't always translate to better patient health, right? You're checking the box, you're getting paid more, but the patient's not getting better. Does that work? We're seeing a lot of like financial and actuarial engineering and value-based care, a space that I spent a lot of time as we think about the benchmarks for ACOs, as we think about the capitated payments in programs like CKCC and nephrology. A lot of debate around where these benchmarks should be, how these capitation programs should be, calculated, and also like eroding bonus value. As we now see kind of fewer plans are achieving 4 stars, the financial uplift that once drove like that stars focused strategy is becoming less reliable. So I think plans have both bottom line problems and then, top line problems as well. And you see this like continued premium pressure and margin compression.
Yeah, I think so well said. I've spent the last, just a couple of weeks just having conversations about some of that. And Rehan, I guess my question is, or my thought process is really, when we, like you said, gap closure, some of the metrics, it's about checking the box. Have we gotten so far away from understanding or remembering what the intention of these programs is that we are not actually having the impact that we intend to, or we wanted to, because they have become revenue generators. Mm-hmm. Stars, HEDIS, they are revenue generators or revenue supplementers, however you want to say it, for providers and payers through value-based care and through just some of the incentives that are available. I think I'd almost, as we think about that or go back to the regulatory conversation, there's definitely a lot, like Tom outlined, a number of conversations and bills that are being presented at the state level. My question is, where do you guys think CMS is going with some of the new administration, and what might they choose to focus on from these metrics, and how might AI start to really influence the process, the structure of healthcare in this country? I'm not talking about a single payer system or that movement, but how can we use the technologies, these new opportunities to maybe flip the dime a little bit?
For sure. I mean, look, we're seeing CMS retroactively recouping Medicare Advantage overpayments. Mm-hmm. It's a huge topic of conversation right now. With the new version 28 risk model, we saw CMS, the final rate notice, it's lower benchmarks. Again, that just means less top line revenue for plans. We're seeing site of service scrutiny, a lot of attention on shifting care from expensive hospitals to cheaper outpatient settings, moving into the home, moving into SNF, moving into ambulatory surgery centers, more ambulatory services. And there's a lot of bipartisan momentum against Medicare Advantage overreach, right? This is a popular talking point on Capitol Hill right now. There's a lot of consensus around basically eliminating upcoding, which is what happened. So I think plans get that. It's like, business as it was is going away. And by the way, our costs have gone up because MLR is going up. Like, what do we do? And I think that is the perfect soup to your point, which means like we need to look at new tooling to help decrease bottom line, to help increase top line, kind of in this background of regulatory chaos.
Yeah, and when you think about everything you just said, what are we doing to as we shift care from inpatient to outpatient to the home perceptibly? What are we doing to support that?
Yeah.
Like, are the supports available? Are we supporting, caregivers? Are we supporting services to come into the home? We all talk about it, like, the best place to age is in your home.
Yeah.
It is actually the most difficult place to age.
Yeah, no, that's certainly true.
I can say that firsthand. My dad's now in a assisted living. He was falling. How many times the place that they were at, they basically sent a notice like, we're not assisted living. The fire department. And it's the best place right now, the assisted living. So anyway, I'll stop at that. But You're totally right about that.
Yeah. I've been at a few kind of aging and dying innovation companies in the last 5 to 6 years, and I think on the macro, when the government looks at Medicare and Medicaid budget, and then we pair that with aging population and sicker population, we're in a world of trouble. We're already at the breaking point. I think to your point, there is a lack of funding, a lack of infrastructure, and a lack of policy and regulatory focus on aging and then dying. It's really expensive to die. Some estimates have said northwards of about $300,000. Who has that saved up for that? So I think the entire spectrum, from senior living to post-acute care to palliative care and to hospice, which are areas that we at Guarantee kind of service, I've kind of seen some interesting, I think, trends, especially in the payer and the payvider space. And I mean, there's a couple of intersecting realities here. I think right now, tied to our previous discussion, health plans and risk-bearing entities, they are really focused on bottom line MLR. They have to be. Yeah. And when they look at where's our largest cost, bang for buck, it is in that like frail elderly population. It's that dual eligible Medicare, Medicaid, polychronic polypharmacy, 6 chronic conditions, 10 medications. Those are the members, pound for pound, cost way more than any other member on their plan. And I think there's certainly a lot of the national plans already have really good data and managed services to deal with it. And I think a lot of the local and regional plans that we speak with are certainly interested in leveling up. And I think there's kind of 4 areas that plans are making investments right now. Again, like utilization management and reinvention. And I think this is a perfect place for AI and real-time data. Smarter prior auth, high-cost drug controls, ER diversion programs. There's so much that can be done with smarter 911 triage. Like, if you think about it, I think we're going to a future where if you call 911, an ambulance will not show up. Right? Why would it? It gets diverted either via telemedicine or to another service that's lower cost. Because even that ambulance ride has a bill.
Yeah,
the patient
a very big one.
So I think a lot of plans are really investing in 911 diversion and ER diversion, because decreasing ER visits, hospitalizations, and readmissions is always the top spear for any value-based care initiative. It doesn't matter what. So I'm seeing a lot of focus there, a lot of focus on very strong provider alignment. Historically, payers or providers, lots of abrasion, but especially now with integrated delivery networks, with the payvider model where the payer owns the provider or the provider is aligned to the payer because there's risk being shared, right? Shared savings, shared risk arrangements, with capitation programs. I think that really incentivizes better cost discipline and can also reward very high performing PCPs to be the true quarterback. Now it's very hard. It's easier said than done, especially when you kind of wrap in long-term care, which is oftentimes why the caregiver actually ends up being the quarterback, right? It's the spouse, it's the loved one who is coordinating visits, who's picking up the medication, who's doing patient engagement. I think really smart plans are empowering, educating, compensating the caregiver to do those actions. And then I'm also seeing a lot of like investments in very high ROI care management, disease-specific programs, oncology, individual end-stage organ failures that are very expensive, like heart failure, end-stage renal disease, COPD. These are the cost drivers. Behavioral health. Like NICU stays are really expensive for commercial health plans, right? So finding those individual areas or episodes that are incredibly expensive because there's a lot of inpatient spend or a lot of specialist spend, and then putting together very focused, programs that help the patients.
Well, that was a whole, I feel like we got 3 shows in one on that. Love it. As we're kind of coming towards our latter part, kind of wrapping up takeaways, love to hear your thoughts. We had some great planning out on this conversation. There was mention about Scribes AI. Do we want to talk about some of these tools and technology? I know we've covered a lot. Is there anything towards our latter part that you panelists feel we should just kind of finish off with?
Yeah, Tom, I'm curious, your kind of background and expertise here as you think about how the space is evolving with tools where we saw individual use cases like the clinical note now starting to get automated. We've seen certainly this gold rush of scribing companies. What happens after that, right? Is it pre-visit intake? Is it post-discharge summaries? And then how does CDI kind of wrap into that? What are you seeing?
Great question. I think fundamentally what has me most excited in this space is what the Affordable Care Act really granted us and pushed the entire country to do is to get the data into an EHR. I like to call that interoperability 1.0. And then now we're on the cusp of getting to 2.0. And now that we're getting the data into the EHR, there's a lot of different ways of going about it. My wife works at Children's Hospital in DC, and they actually have full teams that are following physicians around with an iPad to document everything as feasibly and accurately as possible. Because, we all know physicians are now spending 4 to 6 hours of their 12-hour shift back in the EHR and documenting appropriately. And so we have to improve that. And I think with the interoperability standards that are coming out and CMS and NCQA and a lot of the regulatory bodies who are pushing the industry for standardized data exchange with FHIR and TEFCA and forcing everyone in Epic and Cerner and everyone to finally play along, I think we're in a really good position to foundationally build what we need so that the data in and the data out is of quality. Because without that standardized approach and that exchange of data, I think the challenge in AI is all those disparate data sources, the way the data is saved, the way it's interpreted. Without that standardization up front, it's a huge challenge. And so we've seen that a lot in NLP, in the risk adjustment and quality space over the last, really 10, 12 years. And NLP has struggled. I think I'm still hearing now from just retrospective risk adjustment as an example, leveraging AI and NLP to try to add or delete the suggested adds or deletes from an HSE standpoint that are in a medical record that either substantiated or not, so we can, overall just improve the accuracy of that documentation integrity. I think we're getting a lot closer, but still we're seeing a 95% error rate in those adds and deletes. And I think it ties back to the foundational component of the way the data should be structured, translated, communicated. We're really, really close. I think with the 2027 rule and mandate, we're right on the cusp of training these AIs and these tools to get there. I am hearing a lot on at the point of care component, a lot of burnout from physicians, which is we've got to fix that component where AI has been now incorporated at the point of care, and physicians are getting burnt out from really poor suggestions for documentation and the burnout. And then it's a complete lack of trust in it entirely. and then it's never used. And so like, I think we're getting closer, but there's been a lot of positive notes. But I think once we get the data right, the tools will be ready to help in a massive way.
Yeah, there certainly is a paradox where if you look at the marketing of various AI vendors, they're saying, hey, we're going to save you time. When I speak to frontline providers, what they say is very much the opposite, where this actually increases my time. You can summarize a patient encounter, but it actually takes me a lot of time to be like, well, this is wrong, this is right, this is wrong, this is right. I might have just written the note myself to begin with. To your point, inbox messages. Anytime you have messaged your provider through a patient portal, whether that's through the provider portal or through a health plan portal, there are now many tools that provide, suggested responses. Many providers will say the responses are wrong, they are not personalized. It takes me a lot of time to find the right response. I might as well write it myself, right? And I think to your point, Tom, that is where some of the tension, and there's a lot of AI toxicity in the space because some of these vendors are, again, being provided through the EMR, through the practice management platform, through some type of vendor partnership that did not have the sign-on of the frontline clinician, whether it's a physician or a nurse or allied health professional. And now they're being forced to use it because the entity is paying for it. And they're like, well, how do I have to get trained on this? It's a change of workflow, which is always, it provides some friction. So I think there's definitely this kind of paradoxical experience. There are those who say, hey, this is like life-changing. This is game-changing. I'm now able to get home on time. I have a decrease in pajama time. I have an increase in satisfaction. The joy of practicing medicine is back. I'm not just doing this anymore. So there's certainly a variety of responses that I've been seeing.
Yeah, I'd be interested in knowing where that spectrum is, Rehan, in terms of the providers that are on the positive end versus the not so positive end. I know there is a lot of alert fatigue or AI toxicity. I think that AI is as AI does. And really one of the challenges is that AI is a data tool, but if the workflows are not addressed, so if you're not following the workflow of your EHR, if we're not incorporating workflow efficiency and streamlining, the AI tools are not going to be able to correct or appropriately respond to the inherent, the foundational data that's in the EHR. And then when you introduce data exchange in any kind, whether it's unidirectional or bidirectional, now you're just you're creating a conflated set of information or data that is passing from one to the next. And so while I agree that there's a lot of opportunity with what we're seeing and some, with TEFCA, with the data exchange kind of improving and increasing, what I have seen a lot of is I can get data out of the EHR, but it's not being entered into the EHR correctly based on the workflow of that EHR. And so now I'm getting more bad data. And so we've got to think about kind of the workflows, the data that we're getting, and then how does the scribe truly have that opportunity to support the work, the effort of the provider, because that's where some of that data is starting to permeate from. I think what we haven't talked about though is, there's opportunities for AI and scribe utilization within the payer space, especially within their care management solutions. And we haven't seen any kind of major improvement in efficiencies in that space that can truly have a positive impact on the engagement, the care team kind of coordination and engagement as it is being driven by any plan.
Yeah, I think the great point, care management, and also in a prospective or a concurrent based review. I think on the prospective front, and for those that don't know, it's reviewing medical record, reviewing the patient's overall history and preparing for an upcoming visit, and really getting the team aligned clinically. I heard of on stage a couple of my provider friends, 10 days ahead of a scheduled appointment, they're actually reviewing the upcoming panel of patients that are scheduled to come in. And I think that basically extraction of all of that medical record history, all of the things that go back years. And imagine an individual, especially if a health system moved from one EHR to another at some point, all that lost data, like finding a way to have all of that stored in a centralized way and have an AI to be able to pull from that. And then with a trained model to suggest certain things and questions to ask and potential ways of improving the coding accuracy. I think on the prospective front, AI has proven itself to be really useful, but it's been challenging. But I think that's an exciting area where we can likely see a lot of improvement.
Well, this has been an amazing conversation. As we wrap it up, I don't know where we start or stop. This could go on 3 more series. I feel like we've opened up a lot more questions than answers. I would love just to hear from our amazing guests, just your just quick, succinct takeaway today, each of you, please, as we wrap it up. I really appreciate your time today.
Thank you, Michael. I appreciate it. I think if I had to take or, pick one takeaway, it's about governance. Really focus on governance, what you're doing, how you're implementing your AI solutions. And then think about once you have governance in place, it's about reimagining what you do in a smart, effective, and structured manner.
Yeah, I would say that payers are navigating headwinds through tech and AI-driven efficiencies, risk-sharing partnerships, and a lot of bottom-line optimization, trying to kind of move MLR control.
My key takeaway would be for those payers out there, trust the teams that you have in front of you, enable them to make the key decisions, to strategically stop staring at your toes and more plan longer term. I know it's very challenging with limited budgets, but find a way to take a step back, work on the business instead of in the business, and assess, realistically, compliantly, in a risk mitigated way, how to leverage some of these tools to overall increase clinical care and overall financial performance.
I love that I did not hear AI on the takeaway. So this was awesome. We talked a lot about AI through this, and we had a great show today. Really appreciate you guys coming on.
Thank you.
Thanks.